Viva Reality, I think, sets a new benchmark for the assessment of claudicants with severe femoropopliteal disease characterized by excessive lesion lengths of up to 18 centimeters and significant bilateral calcification, and suggests that use of the directional atherocath is very efficient in removing atheroma, and that is reflected in the primary safety and effectiveness endpoints at 12 months with a very compelling freedom from CD-TLR and primary patency. The essential takeaway findings from the reality trial are that in a group of patients with long, severely calcified femoropopliteal disease, the use of directional atherectomy prior to the application of an antimitotic is both safe and it's effective. Importantly, an additional finding is that the use of provisional stenting in the treatment of these patients was low, under 10%. I think the third element here is that we've moved forward with a better understanding of the use of the word severe calcification by the application of a novel calcium assessment tool called the PAX index. I think it's important to understand the actual technique employed with this vessel preparation strategy. These lesions, as I mentioned, were long, the mean lesion of 18 centimeters with heavy calcification. The results that we saw at 18 months as it relates to freedom from clinically driven TLR were approximately 93%. Additionally, when we looked at primary patency in the absence of a required reintervention, it was upwards of 78%. So I think when we look at those two metrics, primary patency and freedom from clinically driven TLR at 12 months in a complex group of patients, with significant femoropopliteal disease, I think, although they're one-year data, they give us some cause to investigate further this type of treatment strategy. The other point that must be made beyond the results that I've just suggested as it relates to primary patency and the freedom from clinically driven TLR is the exceptionally low provisional stent rate. You should be aware that there is adjudicated registry data that would suggest that the longer the lesion, in patients that had a primary strategy, a standalone strategy of the use of a drug-coated balloon, that as the lesion length increased, the rate of provisional stenting likewise increased, to the point that once a lesion was greater than 25 centimeters, the provisional stent rate was actually higher than 50%. So it's really important to understand not only the one-year results as it relates to clinically driven TLR and primary patency, but the exceptionally low provisional stent rate. I think the dual use of directional atherectomy and an antimitotic, the argument for this strategy is bolstered by our results. However, I think it should be said that we cannot assume that all atherectomy devices and their method by which they are employed and used are equal. So similarly, I believe that there are issues regarding the class effects of antimitotics. So I would be very cautious in generalizing the use of directional atherectomy and the use of this particular drug-coated balloon, Impact Admiral, to other combinations of atherectomy devices that have different modes of action and other drug-coated balloons.